have an actual case which is going to be presented by one of our GP participants. So we will start. Just wanted to check whether is everyone come in, because I can only see 2 participants, and normally we have more people than that. There's nobody waiting in the waiting room.
Is this? I can still see there's people waiting in the waiting room. 8 people.
Oh, you're on mute, I think.
Sorry,
there's more people coming in now.
There's more people coming in. Yeah. Okay.
Yeah. All right. We'll just wait for a minute for everybody to their camera and their microphones to start. Excellent. That's everyone coming through. Yeah, that's more like it. As usually more than 2 people. All right. When everyone's little icons have said connecting to audio, then Duncan, I'll just welcome everyone again. Okay. All right, everybody. Good evening. Tonight we have our 6th session, on which we're talking about dementia and sexuality. We have got Duncan McKellar from Dementia Support Australia with us. We did already do an acknowledgement of country, but seeing as not all of you were here, I will just do a brief one again, just to say that we acknowledge the traditional owners of the lands on which we're meeting today and pay respects to elders past, present and emerging, and any Aboriginal and Torres Strait Islander people who are with us tonight. So Duncan, you probably all know Duncan. He probably needs no introduction, but he works for Dementia Support Australia and is a psychogeriatrician. That's right, isn't it, Duncan?
Yeah.
Who has a lot of expert knowledge in the behaviours that can be associated with dementia. And so tonight we're going to hear a didactic presentation followed by a case that's going to be presented by one of the GPs. So Duncan, do you want to share your slides?
Sure. Thanks, Steph. I'll do the technical stuff. Hopefully I get it right. All right. And there we go. Excellent. So I did see some names that I recognised as people were entering the room. I even saw my good friend Jetta Schutz turning up. What the heck is she doing coming listening to me? How dare she? But it's great to be here with you all, and thank you very much for having me. And I've been given the challenging topic of talking about intimacy, sexuality, and living with dementia. And I guess particularly because of my role as a psychiatrist working with Dementia Support Australia, it's one of the referrals that we get reasonably frequently. But it can be a controversial and sometimes uncomfortable topic. And it's certainly within the aged care sector, the idea of people presenting in care home settings in particular, but whether or hospital, even sometimes at home, can result in reactivity rather than sort of reflective responses, because there are all sorts of embedded societal attitudes that remain part of the kind of milieu around older people and sexuality, and then particularly if there's a change in behaviour that might be associated with somebody living with dementia. So this context is important, and particularly as well with recent changes in the regulatory environment around aged care. There's been changes such as the introduction of the Serious Incident Report Scheme, which has increased people's awareness of cases because they're getting reported through the CERS process. In Dementia Support Australia, between 2 and 5% of cases referred on a monthly basis to the Dementia Behaviour Management Advisory Service or the Severe Behaviour Response Team involve sexual behaviours. So this is a small but important population. And these kinds of referrals that we receive reflect a whole range of issues, from completely misunderstood behaviours through to investigations of alleged sexual assault. The other thing about the context here is that there is actually, because of these changes, I suppose, practically speaking, in the aged care sector, there's actually been some renewed interest in research into the topic, and particularly as things like aged care legislation has been sort of changing and moving towards a new Aged Care Act. There's a sort of a sense that legislation and policy needs to be founded on principles of human rights, and that's promoted a whole new sort of round of research and thinking into this topic. Okay, so let's establish some foundational principles that should guide us as we look at the issue of intimacy and sexuality in people with dementia. So first of all, it's really important that we take a compassionate, person and relationship-centred approach. It's foundational. We do need to adopt a human rights conceptualisation of care rather than taking an approach that is institutional or paternalistic. We need to understand the legislative frameworks that relate to guardianship, including the limits of guardianship. And we need to understand principles of capacity and consent, including the nuances of capacity. And it's also important to be aware of cultural and societal beliefs, values, and assumptions, and navigate these both respectfully but insightfully, recognising that sometimes what happens around the assessment and the management of sexual behaviour in people with dementia reflects attitudes and assumptions rather than clear thinking around the topic. And it's really important as well as a foundational principle that relates to how we work with older people and people with dementia overall, but in particular with an issue that can be provocative or controversial in any way, that we recognise that language really matters. And we need to commit to non-judgmental, accurate and humane language. I think about my own experience and the kind of cases that come across my desk in Dementia Support Australia. And sometimes I'm quite shocked, not by the presentation the person with dementia might bring to us, but oftentimes the attitudes and the language that care providers might use. So I've heard language used like things like people being called a sex pest, for instance, because of their behaviour being perceived as highly unwanted in the context of a care home. I've heard people's behaviour described as predatory. And if you think it through, that's really not often a very helpful way to describe somebody with dementia who probably presents with a changed awareness of the significance of their behaviour. So let's think about some key definitions. So when we use the term sexuality, what are we talking about? Well, one of the foundational things here is that sexuality is a central core component of being human. And in much of the literature, in a contemporary setting, it's also characterised as a fundamental human right. Sexuality encompasses sex, gender, identity, sexual orientation. It encompasses reproduction and intimacy. Expressions of sexuality include thoughts, fantasies, desires, beliefs, attitudes, values, relationships, roles, and physical sexual behaviours and activities. If we move on and think about intimacy, intimacy is related to sexuality, is included in sexuality, but also has a more nuanced kind of meaning. And particularly it relates to relational qualities, reflecting interdependence and touching on emotional, cognitive, and physical intimacy. Intimacy can encompass relational engagement, from platonic relationships through family to romantic and sexual connections. So it's a much more broader and more nuanced term. And one thing to think about is that in ageing and dementia, if sexual behaviours become more difficult because of physical, cognitive or environmental limitations, it may be that intimacy becomes a much more important means of maintaining connections, relationships, identity and self-worth. And it's important to remember the relationships between intimacy and sexuality, but also to understand the differences, and that intimacy-seeking behaviour might be interpreted as sexual behaviour, but in fact may be quite different, that the person may not be looking for sexual activity, that they may actually instead be looking for intimacy and personal connection of a different sort. If we think about sexuality and ageing, there is a persisting false perception held by at least some, maybe not many, but some health and care providers, that ageing somehow results in a non-sexual human status. Now, of course, we know that this is false. And in actual fact, the research shows that the majority of older adults continue to engage in sexual activity really throughout their lives. One of the things about getting older is that ageing may reduce the frequency of sexual activity, but it may actually result in an increase in sexual sensitivity and a change in the dynamic of sexual experience. So one of the fundamental things here is that we really have to deal with this idea that being older is somehow to become a non-sexual person. Okay, then let's think also about the impact of dementia on sexuality. So people with dementia may present with either reduced or increased sexual behaviour. It's not just one thing. So, of course, apathy can be a core symptom of Alzheimer's disease, for instance, and may result in a reduced interest in sexuality. But equally, people can present with hypersexuality and increased levels of sexual behaviour. In dementia, reduced reliance on symbolic and verbal behaviours might result in an increased prominence of physical behaviours. So, in fact, what the person will do is to replace that ability to use language, for instance, to communicate need with a behaviour instead. And we see that across the board with people presenting with changed behaviours that reflects needs that they cannot necessarily communicate verbally. People might experience disinhibition and change in executive function and a change in that ability to make decisions or to manage what is socially acceptable. People experience confusion. Delirium can have an impact on sexual behaviour. And another very common presentation is people misidentifying either a member of staff in a care home or another co-resident, misidentifying them as somebody that they love, as a partner or a spouse. And of course, very understandably, that can then lead to difficult situations to manage. As I said before, intimacy-seeking behaviours can sometimes be misperceived by care providers as sexual behaviours. And at times, behaviours such as undressing or touching genitals may actually reflect underlying personal needs such as pain, discomfort, restlessness, boredom, etc., and can easily be misperceived or misunderstood by care staff or hospital staff or family members. It's important to think about issues of capacity and consent whenever we have a conversation about sexuality. The fundamental principle here is that a person should be assumed to have capacity unless proven otherwise. This gets more complicated when somebody might come as a referral to a care provider, to a doctor or a health setting, and they're already under a guardianship order that's been made by the Civil and Administrative Tribunal because there's been a determination of essentially global loss of capacity. But capacity is always more nuanced than that and is decision-specific and oftentimes situation-specific. And we need to still come back to this fundamental assumption that people have capacity. And there's some loopholes in the law that actually make this more important when we get to the issue of understanding sexual behaviour in the context of dementia, because in every Australian jurisdiction, it is actually unlawful for any person, including a guardian, to consent to sexual behaviour on behalf of another. So it means a guardian can't actually give consent to sexual behaviour. So if there's a relationship happening in a residential aged care environment and family members get really upset about it, one of the problems here is that they actually can't give consent for that relationship to go ahead. It also becomes problematic if in interpretation if the guardian is then seeking to deny access to that sexual behaviour that that person is seeking, because there's a gap in the law in relation to this particular type of decision making, which is challenging because people often need support in making decisions in the context of dementia, and how we go about doing that becomes quite tricky. This is one of the issues that really creates problems within the aged care context, because it's actually easier said than done to unpack these principles when it comes to a real situation of somebody with dementia engaging in a relationship that is of an intimate nature with somebody else. When thinking about capacity and consent, it's important to consider a number of questions. Things, for instance, like, does the person understand the nature of the activity? Does the person have the ability to recognise the person with whom they are sexually active, or are they mistaking them for someone else? Is that person or their partner able to refuse the activity? And does that person understand the potential risks of the activity? In a situation where we might receive a referral or be asked to see somebody who presents with changed behaviour that includes sexual behaviour, it's really important to understand every time that assessment is the key to management. What this means is we need to seek to understand the contributing factors for behaviours presenting in a person with dementia. Don't just look at the behaviour in isolation, but try to understand what is underpinning the behaviour. What are the antecedents to that behaviour? What is being communicated by that person? What need might that person present with that we might seek to understand? And by understanding how to better meet that need, the behaviour might, in fact, itself change. So in doing this, come back to the first principles. Take a history every time. Take a good history that seeks to understand who that person is, where they come from, what's their story that might give us an insight into how they might present now and what they might perceive as an important need. Wherever possible, do a physical examination. Now, I understand that sometimes it can be difficult with a person with dementia to do a full physical examination, depending on how much they might understand or be able to consent and cooperate with you around that physical examination. But wherever possible, do a physical examination. Consider the behaviour and its trajectory. So think about the ABCs, the antecedents, the behaviour, and the consequences. See if you can get a behavioural picture. Think about potential clinical factors: pain, constipation, urinary tract infection, prostatic symptoms, etc., that might in some way potentially impact on why that person presents with that behaviour. Think about long-standing personality factors. Think about previous history of trauma that might be revisited in the context of dementia. Place that person into the context of the care system in which you find them. How is the environment and the approach to care contributing to the presentation? Consider issues like, is there access to privacy? Consider what are the attitudes of the care providers and how are they engaging with this person and with the behaviour? Is that approach making things better or is it making things worse? Look for red flags of abuse and exploitation. There can be physical signs, for instance, bruising or injury, especially to particular parts of the body, breasts, buttocks, genitals, etc. Think about behavioural signs. So, for instance, is there agitation during personal care, during behaviour or care activities that might be perceived as intimate in some way? Or is there a response to a particular co-resident or a staff member that raises concern about relationship with that person? And the other thing to always keep in mind as well is to be very much aware that the challenges and barriers are greater for people living with dementia who identify as lesbian, gay, bisexual, transgender, or intersex. The problem of sexuality the issue of sexuality is oftentimes problematic for anyone living with dementia, particularly in a sort of institutional care home setting. Those challenges and barriers are magnified for people from the LGBTI community. So when we think about responding to problematic behaviours, the first line is always non-pharmacological. It's always behavioural, environmental, and situational. This includes doing things like optimising meeting that person's needs, identifying those contributing factors to the behaviour and meeting those, or remediating them wherever possible. It involves ensuring meaningful engagement to provide a quality of life and addressing loneliness and boredom. There have been numerous cases that I've come across where the issues are that the person is simply not given enough meaningful activity. They're left to their own devices to entertain themselves, despite the changed ability to be able to self-initiate meaningful activity. So address that need that every resident in aged care across the country has to have a meaningful life that makes it worthwhile getting up in the morning. Consider non-sexual needs for physical contact and comfort. Creatively meet these. So things like, think about sensory input through a weighted blanket or a weighted animal or access to a real pet. Think again, that's about meaningful engagement and quality of life. And the other thing is to educate care providers and seek to modify any institutionalised, stigmatising or punitive approaches to care. Numerous times I have seen that a person's behaviours have been exacerbated by the way that care providers have responded to them. So think about that and think about how can we support people to be less anxious about sexual behaviour in people with dementia and more able to then think about how to creatively and supportively assist that person so that their needs can be met, but done so in a dignified kind of way. Again, with non-pharmacological responses, de-escalation and distraction are always important. Some principles are to remain calm, be patient and respectful. The person is likely to be unaware that their behaviour might be perceived as inappropriate. Always speak gently but confidently, speak slowly and simply. Use non-verbal cues to reinforce your message. Distract and redirect focus to another activity. If possible, remove the person from that place or from person-based triggers, or manage those triggers once you learn what they might be, so that you're preempting situations that might be difficult for people. And encourage moving the person to move to a more appropriate location, ensure privacy, or consider making a referral to Dementia Support Australia, who have a team of people who do this as a specialty to look at how can non-pharmacological and behavioural support be provided in the context of care. The Dementia Collaborative Research Centre has developed the sexuality assessment tool for residential aged care, and this provides guidelines for supporting expressions of sexuality in people living with dementia. And this tool sets out a number of principles and practices. So it suggests, for instance, providing do not disturb signs in aged care environments, thinking about providing double beds or double adjoining rooms for people living as a couple, supporting people's right to request and use sex aids or sexually explicit material in the privacy of their own rooms, providing the same level of assistance with personal care surrounding sexual activity as for any other activity. So not being squeamish after somebody has perhaps engaged in a sexual activity, but recognising that that person may still need support with personal care. Enabling people who wish to use the services of a legal sex worker as recommended as a potential response, and providing opportunities for intimacy or expression of sexuality in social settings and activities. And that really relates to recognising the need to support people in identifying their sexuality if they're comfortable to do so in a care home setting. And then I'm going to move towards the end as well and touch on some of the pharmacological management strategies that might be considered as a second line of response to somebody presenting with sexual behaviour in dementia. So firstly, consider any potential contributing clinical causes of discomfort and treat those. Like we said before, urinary tract infection, urinary frequency, prostatic hypertrophy, constipation, changes in mood or mental health. If there's something that could be contributing to this person's changed behaviours, identify those things, and if it's treatable, think about treating it. If you specifically need to trial a pharmacological treatment for sexualized behaviour, the first line would always be a trial of a selective serotonin reuptake inhibitor, an SSRI, so the antidepressants. So citalopram and paroxetine have some evidence of benefit for people with changed behaviour of a sexual type in dementia. And really, essentially, you're using a side effect profile to achieve that outcome. The second line would be to consider a trial of a mood stabilizer. So carbamazepine has some limited evidence. Gabapentin has some limited evidence in the literature for benefit. And again, it's really using side effect profile to dampen down that person's libido. And that's, sometimes that may be something that needs to be done, but it is essentially a chemical restraint. And it's really important that we recognise the potential ethical challenges around that. The third line would be to consider a trial of an antipsychotic like in low dose, like quetiapine or risperidone. And again, that's the dampening side effect profile that's being used there. And the fourth line to think about is then a careful trial of an androgen blockade, so something like cyproterone acetate. And that really needs careful consent and consideration. And I would strongly suggest that it's best to avoid injectable options, things like Depo-Provera. And I've certainly seen them used in residential aged care, and I would strongly advise against using those sorts of really heavy-handed hormonal modulators in order to manage this problem. Nearly every time there's some other strategies that could be brought into play situationally and from a behavioural perspective. All these strategies require informed consent, monitoring and timely consideration of withdrawal, and recognise that these strategies are a chemical restraint and they differ from pure symptom management. So lastly, some final thoughts. Always apply a compassionate person and relationship-centred approach underpinned by an understanding of human rights and dignity. Consider how to facilitate and support the person's right to express their sexuality in satisfying, safe, private ways with dignity, rather than just merely trying to contain it or cease it. Always use non-pharmacological, behavioural, environmental and situational management as the first line. Seek assistance whenever needed. Make a referral to Dementia Support Australia, 1800 699 799. And if you have to use pharmacological interventions, then do so cautiously with consent and with commitment to review. And there endeth the didactic lesson. So really keen to hopefully we can look at how we can put some of those things into practice through the case.
Excellent. Thank you, Duncan. So before we move on to the case presentation, I just thought I'd let you know who's in the panel, because one of our panel members is Jackie, who is, her camera isn't working. Jackie Kerr is the specialist nurse. Jackie, where are you? Oh, there you are. I can see you.
My camera is working now, and I've got the background attached.
Oh, hooray. Hello. Welcome, Jackie. Nice to see you. Has anyone got any questions for Duncan about that presentation, which was excellent? Thank you, Duncan. You managed to cover a lot of material in a short space of time. Does anyone have any questions?
Verbal diarrhea.
It's quite a difficult topic to cover in 20 minutes, but
it is. Yes,
you did
really
well.
Skimming over some issues.
Yeah. All right. So if not, perhaps we could ask Delia. Where are you, Delia? I can see you. Would you like to put your camera on? Hello. Oh, you did have it on before. I didn't know that was you. Hello. Welcome. are you able to share the case for us? Thank
sure.
you. And then if you wouldn't mind, Delia, just go through the case with us, with the group, and then pose your questions at the end, so that we can have a chat about it. Thank you. I can't hear anything, so I'm wondering, are you on mute or are you're on mute, just got to unmute yourself. The little microphone on the bottom left. And are you unmuted? No, you're still on mute. It's just a little audio. It says the bottom left-hand corner of your screen, except if you're on a phone, and then that's a bit more confusing. Hang on.
I might just unmute her myself.
Can you do that yourself? Oh, thank you.
Yeah, it's okay. I'm just gonna stop my screen sharing for now, get out of that, and then I'll find link in a second. We'll ask to unmute and
We still can't hear you. We're just working out how to unmute you.
yeah, I've requested for yeah, still not.
Are you on a phone? Right. Okay. If you're on a phone, I think you have to swipe across or swipe up, and you'll see the camera. It's a bit more confusing. It's at the bottom of the camera. I mean, bottom of the phone. I think.
Yeah.
I'm just gonna see if I can see where it is on my phone, but I'm on the computer, so give. I'm just gonna log in on this, and then I'll tell you where it is.
I don't think we can see you either, Delia. Yeah.
We can see you. I can see her.
Oh, you can?
Yeah.
Oh.
It's a little button. Is she logged out now?
She logged out. Oh, okay. Yeah, I couldn't see her.
I could see her. If not, perhaps pop the case up, and while she's logging in, I'll start. I can start talking.
Okay, sure. I'll pop it up.
All right. Hopefully, Delia will be back with us in a second. So this is a 94-year-old gentleman who's currently living in a residential aged care home, and has been living there. Originally was living with his wife, but unfortunately she passed away 5 years ago. He has got quite advanced symptoms of dementia and has had progressive cognitive decline over about 8 years, and is able to recognise family members and staff members, but doesn't have some of his executive functioning and judgment has been affected. There was a significant deterioration between 5 years ago and then again at 2 years ago, where he was really struggling with basic orientation of trying to do simple puzzles. You can scroll down a bit further. So you can see that his verbal ability is also affected, and as we know, dementia is progressive and it affects the whole whole brain. So now his mobility is affected and he's having trouble with swallowing. So he's on a soft diet and is kind of dependent on support for all of his personal care as well. Has had some difficulties with behaviours around that personal care and can be at times a little bit uncooperative, but we don't know really what the reason is for that. It could be that could be lots of different reasons. I think Duncan mentioned it's really important to find out about what is the particular trigger. So it could be something like it's the wrong time of day for the individual, it's not their usual time of day for personal care, or it might be that it feels a bit rushed, or it might be that it's just a bit intrusive for that person. He's having some non-pharmacological support in terms of falls management and podiatry, and also there's some lifestyle support within the residential aged care facility as well. But he's also experiencing some of that apathy that Duncan mentioned is common in Alzheimer's dementia. There are his medications, so you can see be interesting to have a little chat about those medications as well, and whether their medication review might be appropriate. He's on previously had been on pregabalin and he stopped his statin. So there have been some cognitive tests done within the residential aged care facility, and that has demonstrated that there's also been that progressive cognitive change. So he was able to make some statements around how he wished to be cared for through the means of an advanced care directive when he had capacity, where he said that he didn't want any life-sustaining measures and wanted sort of minimal treatments and wanted to avoid hospital as much as possible. But he had experienced a bit of grief when his wife had passed away. So during the time that he lived with his wife in the care facility, they shared a room and had a small unit that they were able to share together. And they would have some times together where they would have intimacy together, and that was something that both the wife and the husband were comfortable with. But on the passing of the wife, he still had some sexual needs and would use a photograph and a pink blanket to have some time, a private time for himself. But over some time, he stopped asking for that blanket, and recently has been experiencing some further changes in behaviour where he's undressing in the communal spaces and around a female resident. So the advice that has come through the staff and also through Delia was to perhaps offer him the pink blanket again and some further private time to see if that might meet his needs of sexual desire. But unfortunately, he has been unable to recognise the pink blanket as something, a piece of material of meaning to him, and this hasn't really made any change to his behaviour. So the questions for the panel were, how would you manage the behaviour that's occurring in the dining room and is causing some distress to other residents, especially those that have perhaps more mild to moderate cognitive change and are aware of what's happening? And the second question is, in aged care home residents, can they have their sexual desires addressed by supplying them with visual material that may stimulate this? But due to this gentleman's cognitive decline, it appears that he's not able to be aware of his wife's image. So are there any other means by which we can help him with his sexual desires? All right. Has Delia, oh, she's reappeared.
Yeah,
oh, sorry. Hello, I took over
Hello.
and just read your case for you.
That's fine, yeah. I got kicked out somehow and it took a while to get back in. So
Okay, all
sorry.
right. Did you hear what I was saying? Did I miss
No,
anything?
sorry, I missed the whole thing, but I'm sure you did it
Okay,
all
I
very
pretty
good.
much read your very, very good description out, and I just got to the questions,
Yeah.
which was some stuff around how do you manage this behaviour that this gentleman's experiencing, and I was going to get Duncan to see if he could offer some advice.
Yeah, sure.
Okay, well, I'm happy to start, and look, I'm very aware that other people might have suggestions that they'd like to bring to this case. With this particular case, I would see that this should be able to be managed very situationally, by which I mean that this is a matter of care staff being able to really connect in with what's happening for this gentleman, and understanding the pattern of behaviour, knowing when are the problem behaviours occurring, and then really building a plan around that to minimise the risk of that reoccurring. So when he if he shows any sort of evidence of wanting to express himself in a sexual manner, then giving him, being aware of that, seeing that, and then setting that up so that he can do that with dignity in privacy, and supporting him to move to a space, and engaging with him in a way that is taking him along for that journey to sort of comfortably relocate to his room, for instance. Recognizing that if this is happening more at meal times, then possibly it's about changing what happens at meal times for him. So he might actually need somebody to sit with him and engage with him during that meal time, rather than just what often happens in a care home context is that people get plonked down, their meal gets plonked down, and they get left to work that out for a lot of the time, unless they actually need support with eating themselves. So it might be that actually his mealtime needs to be timed in such a way that somebody can actually sit with him and engage with him verbally and through relationship and communication, and spending time with him, so that there's actually some connection that's happening there that actually is a distraction from then ending up in the sexualized behavior. So those are things that care homes can do, but care homes tend not to be very good at doing a lot of the time, because they become very task orientated rather than relationship orientated. So it's really then about shifting the mindset of the care staff to think about how do we situationally adapt so that we reduce the sort of the opportunity, or that he's going to sort of fall into that behavior, which almost seems a little bit habitual now, that and less sort of cognitive, certainly not cognitively necessarily aware of the sort of social appropriateness in the environment around him. And the other thing to say before I hand over to somebody else is that really this presentation is less a function of the gentleman in the story, and more a function, or more a dysfunction of the environment itself. This behaviour is only problematic because this gentleman is living in an institutional setting. So that the more relational that setting can become, and the less institutional and paternalistic it can become, and task orientated it can become, the less likely he is to engage in that behaviour inappropriately. And he may still be able to express himself sexually, but the environment should be able to be managed in such a way to give him appropriate opportunity for that behaviour to occur in privacy and dignity.
So we yeah, thank you. We've tried that. So we tried to redirect him back to his bedroom, and I think she would have read, and give him the blanket of his wife. But it sadly, because he used to go then after lunch and be by himself. But yeah, sadly he did not even know where the blanket was, so he was not receptive to any of that. And for that part, I don't know what else. Yeah, or how else to engage with him to explain to him that there is a private time and a private place. He doesn't seem to understand that.
No, so he may not understand, but I would anticipate that could be established for him with some creative and careful and sort of astute thinking from staff who know that behaviour is likely to be coming. So then setting it up for him. And in a sense, he doesn't really necessarily need to understand. It's really then also because you're also then protecting other people from the distress of being exposed to that behaviour. So it's managing the environment in such a way, but not doing it in a, it's not just sort of trundling him off to his room. It's engaging with him to make sure that he's got time there. And the reality is life is not perfect. And so life in a care home is never quite perfect, but it's queuing in, I think, and it's difficult for staff to do that. Oftentimes they don't necessarily have the training to do that. They may not, they are busy people, they've got lots of tasks to get through, so it's tricky for them to sort of switch their thinking, but I'd still be recommending that they do that. This is the kind of case that someone from Dementia, one of the consultants from Dementia Support Australia would be very good at helping model that behaviour, to help upskill care staff to know how to actually manage those moments of redirection in a way that then don't seem like they're just sort of telling him off or moving him, but are working with him to do that. So I'd really recommend this would be a great case to put a referral through to DSA.
Yep. Right. Yeah, thanks.
Jackie, did you have anything you wanted to add?
I'll just say that I think that with this sort of topic, it is really difficult to get some consistency in the way that that care staff actually manage this sort of behaviour as well, and because it's really hard, because people do put their own values into these situations, and so it does take a lot of education and support, but it's really hard to get that consistent approach too. But it does seem from the case study that it is something that could be anticipated. And so, as Duncan was saying, because it's been a pattern of behaviour, there's an opportunity there to look at sort of distraction and moving to the more appropriate place. But it also requires some consistency on the staff's way of managing it as well, which is difficult to sometimes manage.
Does anybody have any other comments or questions or advice who've been in similar situations in the group? I think if you raise your hand, then I can see whether you do. No? And Delia, am I saying your name right? I wasn't sure.
Yes, you do that perfectly well.
Do you have any other questions or queries that you want to ask?
No, I was curious. I think Duncan mentioned the citalopram, which he has been placed on because I think after his wife passed away, he was quite depressed. But the dose now of the 10 milligram, is that the dose you would advise if you would treat now? I don't think it's needed for this particular patient, but if you had a patient who would not be a non-pharmacologically managed, would that be the dose you would recommend, or is that a different dose of the citalopram for these specific behaviours?
So you'd have a dose range that you could consider based on the person's age, depending on, what's their renal function like, or all of the things that you would normally do to sort of think, oh, how do I choose the right dose for this person? If it's a 96-year-old small woman, for instance, it might be enough. However, ordinarily citalopram is usually pretty well tolerated, going up to 20 milligrams in this age group. Sometimes you might be able to push it a little bit higher. So in a case like this, if it was a case like this and you were looking for that side effect profile, I'd be quite happy to push it up to 20 milligrams as a sort of a initial kind of target dose. I would check serum sodium as a routine to exclude hyponatremia as a potential side effect of an SSRI. And then I'd watch closely just to see how well is that tolerated, and to think about, is it being effective? Is this getting the outcome that we're looking for?
Yeah, great, thanks. Just another question, sorry. I've been working with these people for a long time as a GP. If they are not showing a habitual pattern, so it's not something like this guy's, you know, showing this behavior at dinner or at the table. If that's just, you know, ad hoc, randomly, you know, undressing, trying to, you know, physically come very close to another person, which can be quite threatening then to the other person or experience as threatening. You know, how do you then non-pharmacologically do that? I mean, I know you said distraction, but I mean, do you have some tips for how to do that?
Look, I mean, it's a great question, and this is really, it gets right down to the heart of the issue of how to respond. Look, and this is where upskilling. So I would encourage the care home to really sort of take a consistent approach. Like Jackie was saying, it's that same issue of if you want to manage something situationally. So it's really about getting early intervention. So looking for those early warning signs, as it were, that there's a behaviour that's coming. So usually, if you think about agitation, oftentimes there is an early sign of behavioural change. And people often, you know, what happens is care staff don't intervene, they let that go. And then they're chasing the person with some risperidone down the track because things have gone too far. Whereas actually noticing it early on, being aware that something might happen, and then actually looking at the redirection, and it's not just redirection, it's really looking at an engagement model of how can you connect with that person to actually achieve some distraction. And it might be having to put some more time personally one-on-one into care with them. Now, that is the universal problem in care homes, because there aren't enough people providing care, and there's not enough time to do all the things, and there's all those bits of paperwork that people are now required to fill out. And these are the systemic limitations and barriers to actually providing the care that's needed. And once again, I'd come back to, look, you know, I would be really recommending a referral through to DSA and getting somebody like a dementia support coach in to actually work out what works for this person. If there are these sort of kind of random patterns of behavioural disturbance that are problematic, get somebody in who can focus in on understanding what's underpinning this, and then working out a strategy that can be modelled and then disseminated across the team in that care home.
Okay, yeah, thanks.
I've certainly found in the times when I've gone into residential homes that if you ask people, when did you last have any training on these kinds of things, that they haven't had anything recent, not all that often. So I think, you know, and also the turnover of staff is quite high. So there'll be people coming in who haven't had experience. And so sometimes that it can be that people can accidentally escalate something because they don't know how to manage it. So checking on what level of training has everybody had and how often is that happening, and just asking some questions of the facility themselves might give you some more understanding. Because as Jackie said, it is often our own values or feelings around the, you know, uncomfortableness around it, what to do. People just don't know what to do. So a lot of it comes back to that. Whilst they might not have the ability to always provide one-on-one care, at least if everybody has had some education on it, then that's a bit of more of a supportive environment for care home staff as well, because they're feeling a bit vulnerable because they don't know how to manage it themselves. So that I know that you as the GP can't provide them with the education, but you can stimulate the conversation and say, hey, look, there are services that provide it. And that's, you know, both DSA, DTA, which is Dementia Training Australia, and Dementia Australia, they all have quite useful resources for this kind of thing. And so it's probably, that would be my only other tip.
Yep. Right, thank you.
I think, you know, I had a similar, well, I work more in the community, so I don't work so much in residential aged care homes, but one of the other things that I find quite a challenge, and I'm not sure this gets asked about very often, and so it's probably more common than we know, is that change in relationship where perhaps people are experiencing, the person not living with dementia is experiencing having the person living with dementia have increased sexual needs when they don't want it, and perhaps their relationship has changed and they weren't having sexual intimacy anymore, but then the person living with dementia isn't able to recognize that. And I've had that quite a few times, and people find it hard to disclose. So I guess one of the things, if you are seeing carers, it is worth asking about, anything like that, because people find this stuff hard to talk about, and they don't, not that I have any massive answers for it, but I think it's an unspoken issue that we ought to be mindful of. Yeah, well, unless anybody has any other comments or questions, we might be finishing a bit ahead of time.
No.
So what's our next session? It's guardianship, isn't it?
Yeah, it's SACAT and advanced care.
SACAT and advanced care directives. Yes.
Yeah.
So I don't think we have has anyone got a case for that one? Have we got a case yet?
Out, and then hopefully, I encourage everybody to send in a case as well. So I'll send an email out and follow up on that. And
great.
Yeah,
so if anyone does have an interesting case that they want to talk about in relation to SACAT, that would be really great. And that's our last. And remember, you get extra points. Points mean prizes at the end of the day. Well, CPD prizes anyway. So you get reviewing performance prize for that. All right. Well, thank you for attending, and we will see you on the 16th of, that's right, isn't it? 16th of July. Yeah. All right. Thank you, Duncan. That was excellent.
All right. My pleasure.
Thank you.
Thanks, everybody.
If you stay on for a minute at the end, we'll just have a quick debrief.
Yes. Cool. Thanks, everybody.
Thanks.
Thanks, Delia.
Yeah.
Excellent case. It was an excellent case.
I don't have that many, but good.
Thank you.
It's a good case.
Bye.
Excellent. Just us. This crazy puppy, she's going crazy in the background.
Have a blanket with her, or has she just?
No, she had a little sleep on me during Duncan's soothing voice kept her asleep. No, and then she's just gone crazy. She's going crazy right there. Well, that was good. Thank you.
Yeah, it's hard to tell, isn't it, on a sort of webinar like this. It's really hard to get, people have their cameras turned off and